People are logging in. I want to thank everyone for joining this panel discussion today called Jumping Through the Hoops, Who is Deciding My Care? We do have a robust discussion in store, so we'll just go ahead and get started. I will pass it on to my colleague, Laura Wingate, Executive Vice President of Education Support and Advocacy at the Crohn's and Colitis Foundation, to give us some introductory remarks.
Thank you, Sarah, and welcome everyone. We hear about coverage restrictions and utilization challenges from our patients all the time. In fact, 7% of the inquiries to the Foundation's IBD Help Center are related to insurance. And when we polled our constituents about what they wanted to hear about during Crohn's and Colitis Awareness Week, the highest responses were insurance mandated step therapy or fail first requirements, insurance denials of medications prescribed by a provider, and insurance related dose escalation or prescription related issues. We at the Foundation, working with our patients, our caregivers, and our professionals, have observed worse health outcomes as a result of these delays in cares. And you'll hear about some of these challenges from our clinician representatives today, as well as our patient speakers on the panel. It's unacceptable that patients have to jump through hoops to access treatments that they and their healthcare provider believe will work for them. And this game of insurance denials really risks the patient's short and long-term health. There are ongoing efforts in Congress and at the state level to help patients work through utilization management process and quickly gain access to their treatments. We welcome the conversation with the members of Congress and the thought leaders in our community today to discuss the issues posed by step therapy, prior authorization, and utilization management practice, and how we can work together to develop solutions. It's my pleasure to turn the panel over to Sarah Buchanan, our Director of Advocacy. Thank you, Sarah.
Great, thank you for those remarks, Laura. We are joined by a number of esteemed panelists. I'm very grateful to have Representative Rutherford on the line, who's the co-chair of the Congressional Crohn's and Colitis Caucus. Representative Andy Levin will also be joining us, who's a member of the caucus and a parent of patients with Crohn's disease. Sophie Mintz will represent the pediatric perspective with her mom, Dr. Sherry Mintz. They are from New Jersey. Brooke Abbott will provide the adult patient perspective. She's from California. And we have Dr. Faleye, a pediatric GI from Colorado, and Dr. Lord joining us, an adult GI from Washington. Lastly, my colleague Lauren Block will handle questions. So we do welcome questions from the audience, and please go ahead and type them in the Q&A box. And I'm Sarah Buchanan. I'm the Director of Advocacy with the Foundation, and I will moderate this discussion. Before we begin, I do want to level set on some key terms. We are discussing Crohn's disease and ulcerative colitis. These are collectively known as inflammatory bowel disease and impact as many as 3.1 million Americans. These are chronic conditions which cause inflammation of the GI tract, and they can be managed by medicine, medical foods, and surgery. In the images below, you'll see that Crohn's disease impacts the full GI tract, and ulcerative colitis is localized at the rectum and colon. You may hear these terms fistula and stricture as we discuss the consequences for delays in care caused by utilization management. Fistula is an unnatural tunnel that occurs between the GI tract and another organ, and a stricture is a thickening of the GI tract, which can make it difficult to process food or for the GI tract to function. Both of these are painful and must be addressed by surgery. The theme of this panel is utilization management, which includes step therapy and prior authorization. Utilization management, or UM, are techniques used by health insurers to control costs. When implemented inappropriately, the Crohn's and Colitis Foundation has observed that it can cause delays in care and lead to severe or irreversible health outcomes, which is why the foundation supports the Safe Step Act, which requires employer plans to offer a expedient and medically reasonable step therapy appeals process. We also support the Improving Seniors Timely Access to Care Act, which requires Medicare Advantage plans to offer real-time responses to prior authorization requests for certain services. The last slide I'll show before we start the discussion is this graph, which really illustrates the need for timely access to care. You'll see the blue line represents inflammation of the GI tract, which can be addressed by medicine. In this graph, it goes up and down. The sandy brown line represents damage to the GI tract and scarring. This line does not go down. It can be progressive and irreversible, and the only way to address this damage to the GI tract is via surgery. That's why when patients and providers are deciding a treatment regimen, they're really focused on medicines that will help get that patient into remission quickly to avoid any further damage to the GI tract, which again is irreversible and requires surgery to address. So with that, I will stop sharing the screen and I will pass it on to our panelists to provide a two-minute introduction. We'll start with our patients. Brooke, I'll turn it over to you.
Thank you so much, Sarah. Thank you for having me today. Hello, everyone. My name is Brooke Abbott. I am a patient with ulcerative colitis. I am also a mother. I am currently back in school as a student, and I am a patient advocate. I co-founded IBD Moms, which is a resource group for moms affected by IBD, either as patients or as caregivers. And I also run Crazy Creole Mommy, which is my own personal blog and platform talking about my disease and being a single mom. I started having symptoms in 2001, which was my freshman year of college. I was not diagnosed until 2008. Unfortunately, in 2012, I ended up having my colon removed, and I now live with a J pouch. I'm still on medication because not just because of my IBD, but because of the extraintestinal manifestations that IBD brought. So, excuse me, I'm currently living with several autoimmune diseases in conjunction with having ulcerative colitis. My day-to-day life is pretty up in the air. Some days, I'm great. For a time, I was a baseball coach and I was very active in my child's school. I was, a parent volunteer. I would go on field trips. And then there were times when it wasn't so great. And that was actually around the time when I did not have full access to my medication. And it seems to be that when I'm able to have access and my full dosage of medication, I'm doing all right. But when that access is cut short or minimized, that's when I run into issues. And so my quality of life is not just affecting myself, but it's affecting the people around me. Most importantly, my child, who's only 12 years old, he's been living with my disease since he was born, and is a part of this roller coaster that I'm also on. And so I'm just hoping that soon, very, very soon, patients like me and pediatric patients will have access to the treatments that their doctors are suggesting and wanting to provide for their patients.
Great, thank you. I'll pass it to Sophie and Dr. Mintz.
Thank you for having us. So Sophie's journey with colitis began when she was 9 years old. She's tried multiple therapies over the years, but most stopped working or caused severe side effects. We eventually found Entyvio, which worked really well for 2 years. But in December of 2020, Sophie started flaring badly and was hospitalized for IV steroids and a colonoscopy. And at that time, her doctor advised the medication Xeljanz to quickly induce remission. However, our insurance company, Oxford, denied coverage for Xeljanz, citing step therapy as the reason for the denial. However, 2 alternative drugs that Oxford listed were in the same class as a drug that Sophie had reacted to severely in the past, and a third drug would not work fast enough to stop her flare, so we were stuck. 2 months later, Sophie was no better and had to undergo another colonoscopy. We went back to Oxford requesting Xeljanz once again, and after being denied on both primary and secondary level appeals, we arranged for an external appeal through the state of New Jersey and finally won. Oxford also used step therapy to deny Injectafer IV iron to correct severe iron deficiency. And only after a much weaker iron failed did Oxford finally authorize Injectafer. So in the end, it took nearly 4 months 1 hospitalization, and 2 colonoscopies before Sophie finally got the medications that she needed.
And to build off of that, not only did these delays harm me physically, but they interfered with school and prevented me from playing soccer. As more medications were delayed, I became anemic. I didn't realize the extent of this effect until I had soccer practice one day and couldn't breathe after warm-ups, and I experienced levels of exhaustion that I've never felt before. If I were to get medications sooner, more specifically the correct medications, I probably would have been able to play soccer and live life like a normal teenager. Unfortunately, I recently tore my ACL and again cannot play the sport I love. I certainly would have had more time with soccer if insurance wasn't a major issue. I'm also a serious student, and these delays caused me to miss school, which only stressed me out more. Overall, these delays truly put a pause button on my life, and I really hope no other kids have to experience this. Sadly, insurance companies will keep playing games with our lives until the laws change. I deserve better, and so does everyone else living with Crohn's and colitis.
Thank you.
Great, thank you, Sophie. I'll pass it on to you, Congressman Rutherford, to give a brief overview of your experiences with this issue.
Well, listen, thank you very much. As you know, I'm very proud to be on the Crohn's and Colitis Caucus, co-chairing with Congresswoman Maloney out of New York. And we're both very thankful that, we can help to illuminate this issue. It breaks my heart every time we have one of these meetings and I hear from folks like Brooke and Sophie and how this delay creates irreparable damage. And the idea that, we've got to go through this step therapy is one of the reasons that I, co-sponsored the bill on the Safe Step Act to make sure that we don't have that you don't have to go through that in the future and others that that are coming on. And then, of course, also the whole piece on medical nutrition, which, as you all know, is so important in IBD. And so we're going to continue to push hard on those things. We've asked for, I think there's $1 million in the budget right now for the IBD program. We're asking that to go to 1.5 million. And we're pushing CDC. We just sent a letter to ask them to put that in the bill specifically. And also to address, Sophie, something that you were talking about, and that's this whole pediatrics therapeutics and understanding that, you all can't wait. Time is not on your side with this disease. And so, we're going to continue to do all that we can. I think, these two stories, Sarah, this morning, just highlight for me how important, the Crohn's and Colitis Foundation is in getting this word out and making sure that there are people who make policy, particularly addressing these insurance companies. The idea that, that they can somehow require a step therapy that is contrary to what Brooke's doctor or Sophie's doctor might be asking for and requiring, that to me it's unconscionable. And so we're going to continue to work hard, me and Congresswoman Maloney, to do all we can to make sure that you get the treatment that you need when you need it. And you don't have to wait, and you don't have to go through steps, and that there are therapeutics out there for, our pediatric cases. Because if I'm preaching to the choir, I know, but, people need to understand the earlier this can be diagnosed and treatment begun, the less it's going to cost everybody, the better your health is going to be. I mean, it's a win-win. And so we just got to do better on the insurance side of this. And we're going to continue this fight. So thank you
Great.
all very much. And Brooke, thank you. And thank you, Sophie, for sharing your stories, because it means a lot.
Great. Thank you, Congressman. I'll pass it on to Representative Levin.
Thank you, Sarah. It's great to be with you all. I want to thank Representatives Rutherford and Maloney for their leadership as a rank and file member of the Crohn's and Colitis Caucus. I come to this as a dad. I have 4 kids. Oldest 2 were diagnosed in 9. Today, they are 28 and 26. We have been through emergency surgeries, resectionings, full intestinal blockages, extra intestinal manifestations, and on. And we've had problems with all 3 of the access issues that were on your slide, whoever was doing that. Just recently, I mentioned Saul's 26. So what does that mean? That's when you go off. Thank God for the Affordable Care Act, which requires insurance companies to have allow kids to be on their parents' insurance till they're 26. Saul goes off our insurance. He goes on his own insurance as he's employed. Oh gosh, are we going to start from scratch? Right? It's outrageous. And we all had to get in there and fight. He's on Entyvio right now. He was approaching his 8 weeks. And if we had gone through what the insurance company wanted him to go through, it would have been a disaster for him. And he was, in the end, he was able to get it like early in his 10th week, which wasn't good. Right. But it's so important that we pass the Safe Step Act and have full access for seniors as well through the other piece of legislation. And we've, Representative Rutherford and I and all of our friends are going to really push to get this done in the Congress. This is not a partisan issue. It's an issue, as Representative Rutherford said, and Sophie, as your story showed, it's cost effective to give kids and adults the treatments they need when they need them, because the alternative is way more expensive and just stupid. So, I'm not just a co-sponsor of these bills. I'm on the Education Labor Committee and on the HELP Subcommittee, which is the Health, Employment, Labor, and Pension Subcommittee of the Education Labor Committee. And we're going to really push to move this legislation through so that we alleviate some of these problems with access to care. I'll never forget the time when Saul, our second kid, was on Humira and it wasn't working. He was on, the self-injections every 2 weeks, which is the standard dose that you start with. He wasn't growing. He was late for puberty. He wasn't going through puberty. And his doctor, his GI, the head of pediatric gastroenterology at Beaumont Hospital at the time, did a simple experiment. He did an inflammation test after 1 week, exactly 7 days, and after exactly 14 days. And after 14 days, which is when he got his treatment, it was super high, but after 7 days, it was cool. So we pushed through the insurance company to let him get Humira every week, and his life was transformed.
Yeah.
So he's 26. That was like 10 years ago. And I could still start crying. So we got to get this done, and we're going to fight for you. Thanks, Sarah.
Yeah, thank you, Congressman. And I'm glad you brought up that issue around dosing and getting, off-label doses approved, because that is a common issue that we run into, and one that I know our patients and providers are going to discuss today. I'll pass it on to Dr. Fallier.
Hi, I'm Tolulope Fallier. I'm a pediatric gastroenterologist at the University of Colorado. I work at Children's Colorado. Thank you all. I thank you to the organizers for inviting me to take part in this very important step in improving the lives and the health of patients with inflammatory bowel disease. As I'm just going to tell you about two of my patients, the stories I'm already hearing fit exactly with my clinical experience. The first is, and both of these have happened within the last 6 months, by the way, a 4-year-old who came to me with the chief complaint of diarrhea. Unfortunately, it turned out that she has Crohn's disease. She's very young, and this is a chronic disease. In her age group, we have found clinically, and at meetings like the Crohn's and Colitis Congress, we'll have these discussions of the best medicines for certain ages, for certain types of disease. And for this patient, the best medicine is one of the anti-TNF alpha medicines like infliximab or its cousins, but it was denied because it is off-label for her age group. The problem is, in her age group, nothing is on label because it costs the drug companies more money to do these tests in younger kids. And so when we get to a young child, it's really important that the expertise of the doctor is taken into account, because it is the correct medicine for the patient. And we shouldn't say, well, you're not 8 yet, you're not 16 yet, you're not 18 yet, so you can just suffer until you hit that age. And it does turn into a fight with the insurance companies to cover the medicine. Another issue for very young kids is we find that they need higher doses off the bat, because if you use the lower doses, they just their body just flushes the medicine out, right? Kids heal in general faster than adults do. And so their body will flush the medicine out unless you hit the right doses and the right levels of the medicine, as Representative Levin was just talking about. And so I asked for the higher dose of medicine for this patient, and I did go through an appeals process to fight for that medicine. In the meantime, the delay caused this patient to continue having suffering. She was screaming every time she went to the bathroom. She didn't want to eat. She was complaining of abdominal pain. And this creates stress not only for the patient, but also for her family, who are watching her suffer and just wanting to have her feel better. That stress, we know, can also worsen the family life of the family, as well as add to the problems of inflammatory bowel disease. Because for some patients, stress triggers their inflammatory bowel disease. So it creates this vicious cycle that could be minimized if we get medicine earlier and in the right amount. That's the first patient I wanted to mention. I will say the appeals process was successful in her case, and so we'll see how things go. The second part of that is that medications can take 7 to 10 years to get approved in children after the approval in adults. Again, this is an unacceptable delay. We should not have to wait until that approval is granted before we can help treat our patients. And so a lot of what we're doing is off-label in children, just because there isn't an on-label version that has the desired and necessary effect. I did also want to mention research that has been done by Drs. Constant and Drs. Frank Scott here at the University of Colorado that showed when insurance delays anti-TNF alpha agents, typically those agents are still needed, but there is a delay in providing that care because of the denial from insurance. And what ends up happening in that delayed period is increased hospitalizations and increased adverse effects for the family. My second patient I wanted to mention is a 17-year-old female who started having just kind of some weight loss and just out of the blue, not feeling well. She had some imaging done by her primary doctor, and with what was seen, the primary doctor called our office and we took care of her. We found that she had Crohn's disease. And so based on her disease specifically was the stricturing kind that you heard Sarah talk about earlier. Knowing that stricturing disease responds the best to anti-TNF alpha agents, that's what was ordered. But the delay for her in getting that medicine approved, even though she is in an age group where that medicine should be approved, did result in her having to go to the emergency department twice for dehydration and being hospitalized and having to be put on IV steroids in the hospital because we couldn't get that other medicine for her in the right time frame. If we had been able to get that medicine for her faster, that could have been avoided. And this is not just an issue of the pain and suffering of the patient, which is bad enough, but her family was losing time at work, taking her to the hospital and spending time with her there. She was losing school time, which you heard about earlier, which is very impactful. We know from when people were sent home during the pandemic that the loss of school time is a huge impact in the mental health of young people, as well as your ability to prepare for your future and just act like a normal kid, be able to do normal kid things. And so these issues are extremely important in terms of maximizing health. So delayed medication means more suffering for the patient, lost productivity for the patient and the family, as well as possibly a decrease in the effectiveness of the medicine. Because if you give the medicine after all the scarring has happened, the medicine isn't going to work as well. If you give it early in the course, when it's mostly inflammation, it will have the maximum effect. And that person can get back to being as healthy as we can get them as soon as possible. Thank you for your attention.
Great. Thank you, Dr. Fallier. And Dr. Lord.
Thank you very much, Sarah. And I want to thank and applaud our representatives Levin and Rutherford for not just participating this morning, but also being part of the Crohn's and Colitis Congress. I'm a gastroenterologist that treats adult patients at Virginia Mason Medical Center in Seattle, Washington. And I have to say that the past 10 years has really been a time of change for inflammatory bowel disease. Our treatment options for patients have dramatically expanded. And our ability to help people has consequently dramatically expanded. Gastroenterology is complicated, and inflammatory bowel disease is one of the most complicated things that a gastroenterologist will actually manage. So it requires years and years of training and expertise to actually use these new tools effectively. And there's a constant effort to keep up with the literature and be aware of what the best practices are. And every patient I see is effectively a puzzle that I have to solve, and it takes a tremendous amount of thought and resources and training to figure out what the best course of action is for a patient. And if allowed to use that training and that knowledge, we're actually quite successful at keeping patients out of the hospital, keeping people at school, at work, and really minimizing the societal impact that this disease used to have 20 years ago. Unfortunately, another big change, especially over the past 5 years, is that insurance companies, and particularly pharmaceutical benefits managers to which insurance companies contract, have garnered a disproportionate amount of power in terms of dictating the plan of care for our patients, which is unconscionable to me because were a physician to treat a patient sight unseen with negligible access to that patient's information, it would be construed as malpractice. But these the pharmaceutical benefit manager policies that dictate the plan of care do exactly that. They have a one-size-fits-none algorithm that is applied across all of their patients with inflammatory bowel disease, agnostic to the details of that patient's care, and they simply rely upon the physician to appeal the process if it's medically inappropriate. And so the default actually now is to refuse appropriate care and have the physician appeal into an appropriate plan of care. And unfortunately, that appeals process is extremely resource intensive. This is what we call indirect work, where it's behind the scenes work that there's no time in your day that's budgeted to do it. It's nights and weekends. And we end up hiring quite a bit of additional staff to manage the appeals process and the pre-authorization. Those staff get paid salaries and benefits, and all of that money basically gets packaged into the bills that we send to everybody in the healthcare system. And so effectively, this is robbing Peter to pay Paul. The pharmaceutical benefit managers will raise the cost of care for our IBD patients, which then gets passed on to all of the other patients in the healthcare system to defray the cost of that indirect work that is being done by staff and physicians behind the scenes. And we're effectively able to see fewer patients as a consequence of all the time that we spend trying to jump through all of these hoops. And so this is absolutely unnecessary busy work that serves only to provide an obstacle to effective patient care. And I'm lucky enough to work for a hospital that has the resources to address this. The vast majority of gastroenterology practices do not. And as a consequence, the appeals process does not work, especially when there are delays and inappropriate requests made through the appeals process, and frankly, a lot of dishonesty. We still rely upon fax machines, and the default is for the fax to get lost when we send it into appeal. And so there's tremendous amount of, I won't say mendacity, but inaccuracy that's built into the system as a consequence, a lot of the practices that are currently being followed.
Great.
Now,
Thank you, James.
in terms of actual specific examples, I think that there are so many. At this point, it's the rule and not the exception that my patient's care gets derailed by step therapy, pre-authorizations, reauthorizations. And so I can think of a specific example, though, that came up this year in the midst of the pandemic. One of my patients was about 4 months pregnant when I seem to be frozen. Was about 4 months pregnant when
Great. Well, we will let James's internet kick back in, and I really appreciate all of our panelists for sharing their personal experiences. You know, the foundation has talked a lot about step therapy, and I think there are some studies that indicate step therapy is the most common form of utilization management. But I'm curious, what are other types of utilization management that patients run into? So Representative Levin, you mentioned dosing was an issue for one of your sons. Dr. Fali, I know you've experienced some others as well. I'll kick it to you to start it off, and I want to welcome our panelists to chime in with the kinds of utilization management that they run into.
Absolutely, thank you. So we do run into issues such as we order a medicine and are told we have to start at a lower dose. We have to start at we have to use certain things first, which is the step therapy. We just are told we cannot use something because it's not on label. And the challenge is the science moves much faster than the insurance companies update their guidelines and awareness. And there's times we're talking to the appeals person and they actually don't realize that what they're recommending is not only not the standard of care, but would be ineffective for the patient. And so they're not keeping up. And so when we say, no, this person needs something stronger, something more frequently, something at a higher dose, they often just default and say no, and it just delays care.
I'll jump in. I had a similar situation as Congressman Levin's son. I had been on a medication after my surgery that was working okay. However, they upped the frequency quite a bit. I went from 8 weeks to 6 weeks, and then finally at 4 weeks. And I still wasn't feeling great. In fact, one day I was coaching a baseball game, and one of my little leaguers looked at me and he goes, "Coach Jackson's mommy, you look really not okay." And I was super pale. I was sweating profusely. I just, after a while, the symptoms, you start to live with them. And so you forget that you actually look and feel sick. And so that week I went into to see my gastroenterologist, and we had some blood work done, and it looked like I was kind of falling off at 4 weeks all of a sudden. So we decided to go with another medication. I went through trying to get approval for the medication. I had to go through an appeals process. This whole time, I'm still not doing great. This was a 6-month process. At the 6-month mark, they approved it, but they approved it only if I had a 6-week period between my last infusion and the first infusion of the new medication. Now, my frequency was already 4 weeks, and at 3.5 weeks, I was falling off. So 6 weeks, I'm sorry, initially the approval was for 8 weeks. My doctor at 6 weeks decided he wasn't going to go any longer because I was so sick. I was in fact in the hospital, that he went ahead and just gave me the medication at 6 weeks. And I started early. But that actually created a snowball effect where a lot of other extraintestinal manifestations popped up. And now I'm living with 2 more diseases than I had 3 years ago. And that has dramatically changed my quality of life as a parent, as a student, as a product of society. I've been in the hospital more, and during the pandemic period, it became even more frustrating and hard for me to manage these new diseases because A, they were so new, and B, because the hospitals were filled here in Los Angeles.
Yeah, and Brooke, I'll say, Lauren, I'll cue you to start checking out the questions. And Brooke, I'll say that your advocacy has really flagged for the foundation, especially this issue around access to various kinds of dosing. I think even in this year in California, we've seen a lot of these kinds of denials. Lauren, I'll pass it to you. Are there any questions we can take from the audience at this point?
Thanks, Sarah. Yes, it looks like we have one from Karen Worthington, and I believe, Karen, you've been unmuted.
Yes. Hi, my name's Karen Worthington. My son, Jake, was diagnosed with inflammatory bowel disease when he was 9. And because of the severity of his disease, we had to skip right to Remicade when he was immediately hospitalized, skipped right to Remicade. He was in the hospital for 10 days. And after that, the Remicade appeared not to be working. And our doctor had wanted us to try a vedolizumab drug, in which my son got denied. And they had to go through the appeals process. The doctor did, as well as my husband's company got involved. And by the time we did get approved, I think it was maybe 6 weeks later, my son's disease had progressed so much that he had to have his colon removed. Sorry, I get so emotional about this. Anyway, I always wonder if he had that medication when our doctor had felt he needed it, if he would still have his colon. He is a J pouch now, but he has missed so much school over the past 6 years. We've had to homeschool him twice, and he's been hospitalized with strictures and bowel obstructions. But he did get to play soccer this year after missing out for 5 years because of his fatigue. So there's always a light, isn't there? But I guess my question for you all, and thanks for all being part of this, your stories really all touch my heart. What are the advocacy activities that patients can do that really move legislators to act? So do you suggest in-person meetings, emails, social media, etc.? What can we do?
Thanks, Karen. That's a really good question. Congressman Levin, I think you have to go soon, so I'll pass it to you to respond first.
Yes. Well, let me say 2 things. I'll answer that in a minute. And Karen, I so appreciate you sharing your story, and the idea of your son like starting to play soccer was really moving to me. You're obviously like an incredible mom who's worked so hard for him. So that's, God bless you. I just want to say that there's a huge, when we're talking about access, there's a huge race and class issue, and poor people who have less means just are affected so much more. As much as I want to complain about what's happened to my family, just imagine. So I literally, and I want to call out the PBMs, the prescription benefit management companies, which are such a big part of this problem. But just imagine the advantage that my kids have. I will go on LinkedIn and find executives of one of these companies and invite them to be, linked with me. And then I will say to them, I need you to do this for my kids. It says congressman next to my dang name. How How is a person who's working at McDonald's supposed to take care of their kid? You know, that's why we have to change the system like this. Okay, so Karen, how are we going to do it? How are Representative Rutherford and others, you know, us all together going to get this legislation across the finish line? If you text, email, write letters to your members of Congress, it matters. It really matters. Every week we get reports, how many people are writing about what. Like an example, for me personally, my staff picks out a certain number of folks who contacted me for me to call every month. And I especially want to emphasize meeting in person in the district if you're able to do that. Try for both of your senators and your representative. And the thing is, when I see Representative Rutherford on the floor of the House, like tonight, we'll go in. If we see each other, what do we talk about? We talk about what our constituents said to us. I say, oh, Rutherford, we got to listen. I just heard about this. We got to deal with this problem. So don't diminish the impact you can have if you and your kid go in and meet, or even letters, phone calls, whatever you can do. It really does matter, and it drives what we do legislatively. With that, Sarah, I do have to go to my next thing. Thank you so much for including me, and keep fighting you all, because we're going to get this done and we're going to change things for all the folks with IBD. Thanks.
Great. Thank you for joining us, Congressman. Congressman Rutherford, can I pass it to you? What can advocates do to be the most impactful to make these changes?
Yeah, thank you, Andy. And listen, I would say that, you know, it's very impactful when someone comes into my district office. And, you know, I've even had constituents fly to Washington, D.C. I don't know that that's necessary, but certainly go to their district office, ask for a meeting in person. There's nothing like sitting down and hearing someone's story. That is incredibly impactful. And that's what I would suggest. Have a meeting, and I will tell you, I think probably the most important work that I do as a congressman is this kind of work. It's not just the legislative stuff. It's actually working to solve problems with people back home. When those constituents come into my office back in the district and they're having a problem with an insurance company or the IRS, or, you know, all of these constituency services that we offer, that's really what we're here for. And I think that's the most important part of what we do. And I would say equally or more important than some of the legislative stuff that we do. But go and see them in person. You can do that. At least you can in my office. And if you can't, then you need to find another representative, because they ought to be open to that. That's what they're there for. And I would remind them that, you know, if you can't get in, call the representative next door and see if they'll talk to you. Because now, you know, we very much try to deal with our own constituents. You know, I don't like when you go into somebody else's district. And so that's what I would recommend.
Yeah, that's helpful, Congressman. Thank you. It sounds like those in-district, in-person visits are, you know, can be very impactful for legislators. Dr. Fallier brought up this new study that's, I think it's going to be published in March, led by Dr. Constant, that really underscores what we've seen in the patient community, that these delays in care can lead to worse health outcomes. I think the study said even having a prior authorization requirement like step therapy in the formulary can increase consequences for patients by 12.9% or almost 13%. consequences like surgeries, hospitalizations, emergency department use. Given the urgency of this for patients, I'm curious, Congressman, if I could toss another question to you. What do you think the political will is in Congress right now to try to pass the Safe Step Act or the Improving Seniors Timely Access to Care Act, or otherwise address these issues related to delays in utilization management?
Yeah, well, this is where I think it becomes important for, folks like, Congressman Levin and Congresswoman Maloney and myself to really have those conversations on the floor. Because I can tell you that there are the depth and the breadth of the issues that are up here being dealt with are significant. And that's why these caucuses are so important, I think, is it gives us an opportunity to bring those issues to the forefront. And if we can get enough members interested in it, then we can get it to the floor, we can get it to a vote. You get enough co-sponsors, and that's what we've got to do is, work hard to bring these issues to the top of the discussion and the top of people's attention span. And that's the real challenge. And that's why I say these in-person meetings that you might be able to have with your representative, certainly follow up, as Andy said, with those letters. Because you don't have to just mail to your Congress, your representative. Send them to every representative in the House, because they do pay attention to those. And I think it's important. And so I would say, looking for ways to, and this is where the Crohn's and Colitis Foundation is so important. You have to look for a myriad of ways to bring the topic to the table. And I know that's what you all do, and it's what we try to do up here as a caucus.
Yeah, great. That's helpful. I think we have time for one more question. Lauren, are there any further questions from the Q&A box we should address?
Yes, thank you to everyone who has submitted questions. I regret that we're not going to have time to get to everyone today, but several of our questions are about how we can place more controls on PBMs and insurers as they set their step therapy protocols, and how we can better make sure that people have access to medications, including when they switch doctors or switch jobs and therefore switch insurance without having to go through all of the steps again. So I know that is part of the Safe Step Act, and would love for those on the panel to respond to this point about how you and your different roles can help address these concerns.
That's a really good question. I appreciate that, Lauren. I think you did point out the Safe Step Act does ensure that if a patient is stable, then they should be able to get an exception. If they switch insurance companies or the health plan's formulary changes, they can request a step therapy exception. But that does bring up an interesting topic. We've talked about the problems related to utilization management and some of the poor health outcomes, but what are the solutions we'd like to see? Brooke, I see you nodding your head. James, I know we've also discussed, time to respond to appeals. Dr. Falia, you had some thoughts as well. I'll invite our panelists. Brooke, maybe let's start with you. If you could offer your sense on what should be done to help improve patient outcomes.
Well, time. I'm listening through IBD Moms, we get a lot of patients who are mothers of patients, and time is not on their side. Time was not on my side. If I had gotten my medication earlier, if I had had intervention earlier, I can only imagine what my life would be like right now. And I can only imagine, what I could have done in that time that was taken away from me. So I think that the number one thing is the appeals process takes too long. And I know that that's in the Safe Step Therapy Act, or yes, the Safe Step Therapy Act, that the appeals process should be shorter, but also the control of the process for the doctor to be able to have that control of making sure that they stay in charge of the treatment plan. Being switched to medication because of cost sounds ridiculous to me. And I know it sounds ridiculous to everyone else, but the ridiculousness is, it manifests into serious, dangerous consequences. Karen talked about her child having to have surgery. You know, I now have a disease that I cannot get rid of in addition to a disease that I already had. So these are life-changing situations that happen within, you know, a few weeks' time that could be changed if the gap was closed within 24 to 72 hours.
Right. So getting faster exceptions and faster appeals would help patients get the access to the treatments they need. Dr. Lord, if you're back with us, I'll turn it to you, because I know you had some thoughts on what you would like to see as well.
Well, I absolutely agree that the number one toothiest part of the Safe Step Act is the deadline on the appeals turnaround, because historically appeals can take months, especially when they go through multiple cycles. And so reducing the time of each cycle to a couple of days actually makes it feasible to use an appeals process to direct appropriate therapy for patients who, as Brooke pointed out, time's not on their side. Time is absolutely on the side of the insurance company and the pharmaceutical benefits managers. And so much like in medieval siege, they use that to their advantage. So in the state of Washington, we passed our version of the Safe Step Act at the state level, which unfortunately only covers about 15% of private insurance recipients. But for those patients, the toothiest thing has been that there is a 5 calendar day turnaround time on the appeals process, which has not only resulted in speedier appeals, but also it has reduced the number of default rejections, simply because it's expensive for insurance companies to staff up to the level that's necessary to adhere to such a strict timeline. And so they're much more discriminating about what they will and won't deny. And so what we're finding is just a lower rate of rejections and denials for the appeals. And it's actually cheaper for them now to simply go ahead and authorize what the physician is recommending, as opposed to just by default rejecting everything a priori.
Yeah, thank you, Dr. Lord. And that's a really good point, that I think as many as 30 states have passed similar laws to the Safe Step Act. And it sounds like in the state of Washington, that law is working for the patients that have state regulated insurance. And it's really, you know, up to Congress now to pass the Safe Step Act to make sure that we can extend these protections to employer commercial plans, which is where most Americans get their health insurance. So thank you for making that point, Dr. Lord. I'll pass it to Dr. Fallier, but before I do, Sophie and Dr. Mintz, I'd love to hear your thoughts as well on what you would like to see. We talked about the issues, but what in an ideal world, what would you like to see? But first, I'll cue you, and first we'll pass it to Dr. Fallier, and we'll end on you, Sophie.
I would just say that the conflict of interest for the pharmacy benefit manager should be eliminated. If you get a bonus for saying no to treatments, you are financially profiting, and the people you're saying no to are suffering. And this, to me, should be illegal. There shouldn't be a bonus for that. There should just be a true review. I do understand that medicine is expensive, but we are trying to improve people's lives, which makes everybody's life better, makes our economy stronger. It, allows people, like, we should just really maximize people's health and wellness. And so that's a key issue, I would say, is a way to decrease the number of times that there's just a flat no.
That's interesting. Thank you, Dr. Fallier. And Sophie or Dr. Mintz?
Well, one thing I want to say, kind of just sort of to come off of that, is that there's no accountability on the part of the insurance companies. We went through an appeal, a secondary appeal, and then we went to the state, and immediately the person who reviewed the case in the state agreed that the appeals were inappropriate. But there's no accountability on the insurance company. There's no fee shifting back to them to pay for the cost of these appeals, to reimburse the doctors for their times. And I think if there was some accountability that they were responsible for paying for these external appeals, I don't know if that would change anything, but it just seems like they get away with highway robbery and profit from it while everybody else suffers. So it's such a corrupt system. And I'm a physician myself, so I deal with this on my end all the time. And as a parent, of course. And so did you want to say anything?
Yeah, I feel like there also should be more awareness in insurance companies of these issues. Maybe they're not educated enough about the health effects of these issues. So maybe if they did understand, they would be more willing to help improve situations.
That's such a great point, Sophie. Thank you. And accountability as well, awareness and accountability, great points and things we can think about when engaging health plans on these issues. Well, I want to thank everyone for joining this discussion. I really appreciate the opportunity to talk about utilization management and the delays and the patient health outcomes as a result. I think this has been very informative, and it reflects a lot of what the foundation is both seeing in the field as well as learning from emerging evidence and references. So thank you all for participating. I'll share just one last slide for our audience members. If you are a member of Congress or congressional staff, we do hope you will co-sponsor these bills, the Safe Step Act and the Improving Seniors Timely Access to Care Act. If you are a patient, provider, or a caregiver, we hope that after watching this panel that you want to get engaged and start advocating for these systems changes, as Representative Rutherford and Levin, really emphasize the need to make. You can join the Crohn's and Colitis Foundation Advocacy by signing up at our website, crohnscolitisfoundation.org/advocacy. You can also email us at this email address, advocacy@crohnsandcolitisfoundation.org. So thanks again, everyone, and have a good rest of your day.